Today we will study about the general anesthesia. General anesthesia is concerned, and it's also one of the important topics to be covered, especially the varieties of the general anesthetic agents. General anesthetics, which make the patients to sleep during the surgery and without any pain. That's called as the general anesthesia. And the general anesthetic drugs, general anesthetic drugs are the one which produce reversible loss of all sensation and consciousness. Means after induction of the anesthesia, it is reversible, and the consciousness will be returned after the administration of the anesthetic is over. That's why it is the reversible induction of anesthesia. And the cardinal features of the general anesthesia are the loss of all type of sensation, especially the pain. Pain sensation is totally, it should be devoid of that pain sensation, and it should induce sleep or unconsciousness and amnesia, means pain sensation or loss of temporary memory, and immobility and the muscle relaxation should be reached, because to conduct the surgery the muscle relaxation and the immobility of all the organs it's required, especially the abolition of somatic and autonomic reflexes, both should be stopped. That is the cardinal feature of the general anesthesia. Usually the modern practice of balanced anesthesia, these modalities are achieved by using combination of inhaled as well as the IV drugs. So usually to achieve a very good anesthesia, usually the IV drugs are infused first, then followed by the inhaled anesthetics. That means the induction of the anesthesia is by some of the IV infusion intravenous anesthetics, then it will be usually followed by the inhaled anesthetic. And of course, this is also changed in different drugs and formulations. So anesthesia has developed as a highly specialized science itself, because in the medical practice, the anesthesia specialists are there, and it is a very well developed branch of the medicine. And history, before the middle of 19th century, a number of agents like alcohol, opium, cannabis, etc. were used for making the patient to sleep on the operation table, and sometimes the concussion, means hitting the head with a rod, and also the asphyxia were used to obtain surgical pain. And these were not the good practices as to the part of the patients, and horrible ordeals or the life-threatening ordeals were also seen during this particular stage is concerned. And Horace Wells, a dentist, picked up the idea of using the nitrous oxide, and it's also he demonstrated the effect of nitrous oxide in front of so many scientists, especially it was a laughing gas in 1844, about so many years back only he demonstrated Horace Wells. And however, he often failed to relieve dental pain completely, and the use of nitrous oxide has to wait till the other advances were made, because the nitrous oxide it also induced little analgesia and muscle relaxation, but the pain was not completely relieved. So he could not demonstrate it as a complete anesthetic. And the concussion is a violent jarring and shaking that results in disturbance of the brain functions. So a hammer is taken and hit on the forehead of the patient, and whenever there is a hemorrhage on this particular place, the patient used to lose the consciousness, and at that time the surgery was conducted. But it was a very bad practice that many times the patients used to die while the concussion was being conducted. So it was not a good practice. And history, the Morton, a dentist and medical student at Boston University, after experimenting on animals, gave a demonstration of ether anesthesia in 1846, and it soon became very, very popular, especially the ether anesthesia. First was the nitrous oxide, then the ether anesthesia. Nitrous oxide 1844 and the 1846 the ether was demonstrated, and chloroform was used by Simpson and in Britain for the obstetrical purpose or dystocia purpose in 1847, and despite its highly toxic to liver, and this became a very popular surgical anesthetic because at that time no anesthetic agent was there. Later, the cyclopropane was introduced in 1929, and but the new generation anesthetics was heralded by halothane, especially in 1956. That means about a century back, the halothane is introduced, and after that, the induction and the maintenance of anesthesia, it became very useful and very fast also. So the first IV anesthetic was the thiopentan, and it was introduced in 1935. So here the varieties of the anesthetic preparations, pre-anesthetic preparation which are given the before the induction of the anesthesia is concerned, then the induction of anesthesia occurs. Usually during the pre-anesthesia period, endotracheal intubation is done because whenever a patient is administered with the anesthetic agent, the salivation will be there and it may enter the trachea and aspiration pneumonia may occur. Hence, the endotracheal intubation is done. Then, the endotracheal intubation also helps the anesthesiologist to maintain and monitor the gaseous anesthesia is concerned. And usually, whenever the patient is administered with an anesthesia, and he will be in the stage third of the surgical anesthesia. Later, after the surgery is over, the anesthetic administration is stopped, then post-anesthetic recovery will be seen, especially in case of the patients which are administered with any type of the anesthetics, maybe the inhalant or intravenous type of the anesthetics. And coming to the general mechanism of the anesthesia is concerned, the mechanism of general anesthetic is not a well properly understood science, but a wide variety of the chemical agents or they are going to produce general anesthesia. So maybe apart from the gaseous anesthesia, the intravenous anesthetics were also used, and the combination of the intravenous anesthetic along with that of the gaseous anesthesia was a very popular program. Therefore, the gaseous anesthetic action had been related to some common physicochemical property of the drugs. And Mayer and Overton in 1901 pointed out a direct parallelism between lipid or water partition coefficient of general anesthetics and their anesthetic property, because the drug should be more and more lipid soluble for crossing the blood-brain barrier is concerned, and the anesthetic, most of the anesthetic need to pass the blood-brain barrier to induce the anesthesia and to act on the specific cells in the brain, especially the receptors, GABA receptors. And minimum alveolar, few of the terminologies are there whenever we are dealing with the general anesthetics are concerned. So mean alveolar concentration is one of such terminology and is the lowest concentration of the anesthetic in pulmonary alveoli needed to produce immobility in response to a painful stimulus, or it may be a surgical operation in 50% of the individuals. That means it is the minimal concentration of an anesthetic in the alveoli to induce the analgesia in 50% of the individuals. Just like the LD50 and other terminologies, the MAC is also the lowest concentration of the anesthetic agent, especially in the pulmonary alveoli, and needed to produce the immobility and also the analgesic response. and it is accepted as a valid measure for the potency of an inhalation gases. Potency, yes, the potency means as the concentration of the uh, anesthetic required in the alveoli to induce the anesthesia and analgesia, then it will be more potent. So, usually it remains a constant factor for the induction of anesthesia, especially in case of the young adults. The minimal alveolar concentration of all inhalational anesthetics declines progressively as age advance beyond 50 years, because the MAC of many of the inhalation anesthetics, the mean alveolar concentration, it declines because the respiration and absorption capacity, it also decreases. So the mean alveolar concentration is proportional to the anesthesia is induced. The MAC of a number of gases show excellent correlation between the all gas partition coefficient. So this is another important factor. However, this only reflects capacity of the anesthetic to enter into the central nervous system and attain sufficient concentration in the neurological or neuronal membrane, but not the mechanism by which anesthesia is produced. So the MAC of the gas, it shows a correlation between the oil partition coefficient, but this oil partition coefficient reflects capacity of the anesthetic to enter CNS. As more and more it's lipid soluble, it is going to pass through the blood-brain barrier and reach the respective receptor, and also the sufficient concentration in the neuronal membrane. And the unitary hypothesis is, there is an hypothesis that some single common molecular mechanism like the membrane expansion, perturbation, then fluidization, it's a terminology, is responsible for the action of all inhalational anesthetics, has now been replaced by agent specific theory. So instead of the unitary hypothesis, now it has been the agent specific theory, according to which different general anesthetics produce anesthesia by different mechanisms. So the varieties of the gaseous anesthetics are used, and also the intravenous anesthetics, they act in a different mechanism, type of the mechanism. So this is known as agent specific theory. And recent evidences favor a direct interaction between the general anesthetic molecules with hydrophobic domains of the membrane proteins of the lipid protein interface. So usually what happens, there is a direct interaction with the general anesthetic moiety with the receptor interface of the protein or the receptors. And not only different anesthetics appear to act by different molecular mechanisms, they also exhibit stereotypic or stereospecific effects. And the various components of the anesthetic state may involve action as discrete loci in the cerebrospinal axis. So the different anesthetics, and with the different chemical nature and physicochemical properties, they will enter the brain, especially the brain tissue, in different concentrations, and totally they are going to act in a independent and discrete spaces and also the loci. The principal locus of the unconsciousness appears to be in the thalamus. So thalamus, we have seen the structure of thalamus in the earlier class. So the in thalamus, all these activities are going to take place, and reticular activating system, that's the RAS. Amnesia may result from action in the cerebral cortex, whereas also in case of hippocampus, while spinal cord is likely the seat of immobility in surgical situation. So most of the anesthetics unconsciousness is induced by the thalamus and on the cerebral cortex, effect of the anesthetic on the thalamus and also on the cerebral cortex and also on the hippocampus, whereas the immobility of the animal will happen by the action of anesthetic on the spinal cord. So both of these are very important structure in relation to the anesthetics are concerned. And research findings show that a ligand-gated ion channels, but not the voltage-sensitive ion channels, are the major targets of anesthetic action. Usually, the ligand-gated ion channels, maybe the chloride channels, the GABA-A receptor gate chloride channel is the most important of these. So, gamma amino butyric acid, and among these there are varieties of type of the receptors. This GABA-A receptor gated with chloride ion channel is most important of the varieties of the receptor subtypes. And many inhalation anesthetics, the barbiturates, benzodiazepines, the propofol potentiate the action of inhibitory transmitter GABA to open chloride channel. So GABA is a inhibitory neurotransmitter. So the activation of this inhibitory neurotransmitter causes the suppression of the consciousness and also the pain. And each of above anesthetic appears to interact with its own specific binding site on GABA receptor and chloride channel complex, but none bind to the GABA binding site as such. So, and some inhaled anesthetics and barbiturates can directly activate the chloride ion channels. Apart from that, without acting on the particular ion channels, no receptors or the domain of the particular receptor, directly they can act on the chloride ion channel and activate the chloride ion channel so that chloride ion comes inside more and more and the depression occurs. So many times the barbiturates do this particular activity. The action of the glycine. So GABA and glycine are two excitatory type of the neurotransmitters and the receptors. So a glycine, another inhibitory transmitter, which also activates the chloride channels in the spinal cord and medulla, is augmented by the barbiturate. And propofol is also the recently introduced intravenous anesthetics, and it is very commonly used in case of human beings and also the dog is concerned. So the GABA and glycine type of the receptors are the inhibitory type of the receptors in the brain, and whenever they go and act on the specific receptor, there will be activation of the chloride ion channels, and because of the activation of the chloride ion channels, the patient go to the sedative stage or anesthetic state. And certain fluorinated anesthetics like the sevoflurane, carboflurane, and many more, and also the barbiturates, in addition, inhibit the neuronal cation channel gated by the nicotinic cholinergic receptors, which may mediate analgesia and amnesia. So, fluorinated anesthetics or the barbiturate, both inhalant as well as the intravenous anesthetics, inhibit the neuronal cation channel gated nicotinic cholinergic receptors, which may mediate the analgesia and amnesia. Both can be achieved. And on the other hand, nitrous oxide N2O and ketamine do not affect the GABA or glycine gated sodium channels. So, how they are going to act? Nitrous oxide and ketamine, they selectively inhibit excitatory NMDA type of the glutamate receptor. So here, please see what are all the receptors involved. Number one, GABA. Number two, glycine. Number three, the NMDA receptors. And this receptor gates mainly calcium selective cation channels in the neurons, and inhibition of which appears to be the primary mechanism of the anesthetic action of ketamine as well as nitric oxide. So the mechanism of the ketamine and the nitric oxide is through NMDA type of receptors, and thus the dissociative anesthetic property of ketamine is exhibited. The volatile anesthetics have little action, especially on the glutamate type of the receptors, but the volatile anesthetics do act on the GABA type of the receptors and initiate the ion channel opening up of the chloride ion channels and going to cause the anesthesia. So apart from this one, the neuronal hyperpolarization caused by general anesthesia has been ascribed to the activation of a specific type of the potassium channel called as the two-pore domain channels. Two-pore, P-O-R-E, domain channels, and this may be cause the inhibition of presynaptic transmitter release as well as the postsynaptic activation. Both can be achieved here. The inhibition of the transmitter release from the presynaptic neurons also been related to interaction with certain synaptic protein. So, different facets of anesthetic action may have distinct neuronal basis as opposed to the earlier belief of global neuronal depression. And the many of these local anesthetics which act primarily by blocking the sodium ion channels, especially the lignocaine is going to block the axonal conduction by inhibiting the inward sodium current, or it is also known as the synaptic transmission. And coming to the stages of anesthesia, earlier it was not clear how many stages are there and what will happen in individual anesthesia. Whereas now it is very much well differentiated that the general anesthetic cause an irregularly descending depression of the CNS. So descending means decreasing depression of the CNS. That is, the higher functions are lost first, and progressively the lower areas of the brain are involved. So this is one type of the anesthetic inversely proportional to the brain activity. But in case of spinal cord, lower segments are affected somewhat earlier than that of the higher segments. Of course, this is the reverse action. The vital centers located in medulla are paralyzed. Vital centers, especially in case of the medulla, like sleep, erosion, and many other things, are paralyzed. The last as depth of the anesthesia increase means there are varieties of the stages 1, 2, 3, and 4. As the anesthesia advances, then the stage of medullary paralysis will come. So that's the fourth and last stage of the life actually. The girdle described four stages of the anesthesia, dividing the two stages into four planes. So please remember that there are four stages of the surgical anesthesia. Then there are three planes, third stage and into four planes. You have to remember this very properly. And coming to the stages of the anesthesia continued, the clear-cut stages are not seen in nowadays with the use of fast-acting general anesthetic, because many times the stage 1 and 2 of the general anesthesia induction will be bypassed, and the precise sequence of the events differ somewhat with anesthetics other than the ether. And however, either continues to be used in resource or the poor remote areas, and description of these stages will serve to define the effects of light and deep anesthesia. So this mechanism is mediated by the combination of two or more gaseous or the anesthetics, and description of the stages will stage 1, 2, 3, 4 will define the effects of light and sleep anesthesia. So in the different stages, different varieties of the anesthesia, anesthetic effect will be seen, and important features of the different anesthetics are depicted in the next figure. So here you can see there are four stages. Number one, stage 1, stage 2 is called as the delirium phase, stage 3 is called as the stage of surgical anesthesia, Stage 4 is called as the stage of medullary paralysis, whereas the respiration will be normal initially, then it go on decreasing, and in case of plane 4 of the surgical anesthesia, it is drastically, it is really decreased, whereas in case of the stage of medullary paralysis or the last stage, then there are no respiration will be present and the patient will be totally dead in case of the stage of medullary paralysis. So the ocular movements are normal in stage 1 of the analgesia or stage of analgesia. Then it is little bit disturbing or roving eyeballs in case of the stage of 2, that's the stage of delirium. Then the eyes will get fixed in case of the stage 3 surgical anesthesia, because in case of 4 all the way, 4 stages, the of course the stage 3 and plane 3 is a very good anesthetic stage, but what happens is the respiration go on decreasing and the eyeball get fixed. So here you can see that initially the pupil size will be little small and the pupil will get dilated as the anesthetic stage is going to be advanced, and it is widely dilated in case of the stage 3 and plane 4 of the surgical anesthesia, whereas in case of medullary paralysis, the pupillary dilatation will be seen, and the reflexes, especially in case of stage 1 and 2, usually the eyelid reflexes are there, then they are going to lose, whereas the end of the stage of second this stage second of the anesthesia, the pharyngeal reflexes are lost as the progression towards the stage 3, whereas the corneal reflexes will be present till the end of the delirium, and also exists especially in the stage 3 of the surgical anesthesia. The reflexes to the light and bright light or maybe any light source will be there till the end of the stage 3 and plane 4 of the surgical anesthesia. That's the involuntary movement will be present. It's also known as stage of involuntary movements. Whereas in case of the phase 4, none of these effects are there, especially plane 4 of stage 3. Whereas the blood pressure, it is as usual, it is maintained in case of stage the what you call as the anesthetic stage 1. Then suddenly it is going to increase, and then in the stage 3 it is going to maintain the status quo, whereas the blood pressure will also follow the similar rule. Initially it will be less than in the stage 2 or stage of involuntary excitation, it is going to increase, then it tapers as the stage 3 anesthesia is going to end, and later the animal gets stage of medullary paralysis, whereas the heart rate is going to increase in case of the stage 2 or the delirium, stage of delirium. So then once again the heart rate is going to increase in case of delirium, then it becomes steady in the first and second planes of the stage 3 anesthesia, then once again it is going to increase, the heart rate increases. Whereas the uses of the stage 1 analgesia is for the labor pain, wherever the minor sedation is required and wherever the incision need to be put and very minor operations. So stage of analgesia is enough because the patient doesn't feel any pain and the anesthesia will be induced. Then in case of stage 2, it is not at all useful for any surgical procedures or any other type of the thing. Only it may be helpful in case of the intubation of the endotracheum too. And most of the surgical operations are connected in case of the surgical plane of the anesthesia or stage of surgical anesthesia. That's the stage 3 is very, very important phase of the anesthesia. Stage 3 and also the plane 2 or 3, they will become very, very these expected ones. So the many times we will select which anesthetic is going to cause the fast induction and also maintain it for very long, and that will be an ideal anesthetic is concerned. And the uses of these things are in case of many type of the surgery, stage 3 is induced and the operation is done. But there is a very marginal difference between the stage 4 and stage 3. Hence, one should be very, very cautious while administering the extra dose of the intravenous anesthetics are concerned. Because if little bit more concentration of the anesthetic has been entered the brain, then there is a chance that it causes the stage of medullary paralysis. So to some extent, to some drugs it is narrow, in for the other drug it is wide. The wide medullary paralysis or wide margin of the safety of the drug. And coming to the first stage, that is the stage of analgesia. And this starts from beginning of anesthetic inhalation and lasts up to the loss of the consciousness. So, induction of anesthesia starts with stage 1 of the analgesia. So here the pain will be get relieved, but the patient will not be ready for getting done with any surgical operations. And pain is progressively it is reduced as and when the patient enters the stage 2 and stage 3. And the pain is progressively abolished. Suddenly it is not abolished, and patient remains conscious and can hear and see and feels a dream-like status. So if you have undergone any operation, this you might have all felt, because as soon as the anesthetic drug is injected, he get little bit slow, drowsy, but he will not feel any pain, and he can hear and see and feel a dream-like state, and the amnesia develops by the end of this what you call as this particular stage 1. And reflexes and respiration remain the normal throughout the stage 1 of the analgesia, and through some minor operations can be carried out during this particular stage, maybe extirpation of a warts or the extirpation of external some wound or some thorns, or many times the minor surgical procedures, it is useful. But the stage 1 anesthetic is useful, but it is very useful. It will be for very short duration of the action. So the surgeries which can be conducted with shorter duration of the action can be done by in this stage of anesthesia. And second one is the stage of delirium. Here, this is the one of the disturbing stages of the anesthesia, wherein with the patient lost consciousness to the beginning of regular respiration, and the apparent excitement is seen. That's why this stage is also called as stage of voluntary excitation. So the patient may get shout many times. So the hand he will get struggle and hold his breath. Muscle tone increases and jaws are tightly closed. Breathing is jerky and sometimes there is vomiting, and involuntary micturition and defecation may also occur. That's why the patient is prepared in such a way that his stomach is empty, his gastrointestinal tract should be empty. So he is given the enema and he will be fasted for overnight to avoid all these complications, because if the patient vomits, then the vomited substance may occlude the respiratory tract and it may end up in case of the respiratory pneumonia. That's why all these preparatory preparations are done before the induction of the anesthesia. So usually heart rate and blood pressure may rise in this particular phase and pupils dilate due to the sympathetic stimulation. So it is under the control of the sympathetic stimulation. Then the heart rate and BP may rise due to, in the particular slide we have seen. Here, the BP and heart rate both are going to increase in the particular stage 2 of the anesthesia. Then it is going to decrease. Whereas in case of the stage of delirium, the stage is inconspicuous in modern anesthesia and no stimulus should be applied or operative procedure during this particular stage of the involuntary excitation or this particular involuntary excitation. So because the many times without knowing the patient may shout or cry or express his uh, varieties of the type of the pain, etc. during this particular stage, and hence it should be very carefully observed. This is a very what you call as the disturbing phase to the patient is concerned. And the stage 3, or it's also known as stage of surgical anesthesia, this extends from onset of regular respiration to the cessation of spontaneous breathing. So the spontaneous breathing will be it is very slow, and this has been divided into 4 planes which may be distinguished as the plane 1. So here the rolling up of the eyeballs will be seen, and this plane ends when eye becomes fixed once. So that's the stages where we can start the surgery. And the plane 2 is loss of corneal and the laryngeal reflexes, because in this particular stage the animal is unable to swallow, or the respiration becomes very slow and the cornea fixes and both eyes are fixed. And in case of plane 3, pupil starts dilating and the right reflex is totally it is lost. So if you put the torch also, the pupillary constrictions will not be seen in case of the patient is concerned. Whereas the plane 4, it is the paralysis of the intercostal muscles and shallow abdominal respiration will be seen, because usually the respiration will be abdominal type, but it will be very shallow and the pupillary dilatation will be seen. So, anesthesia passes to deeper planes progressively, muscular tone decreases, blood pressure falls, and heart rate increases with a weak pulse, and respiration decreases in depth, and later it frequently also, and thoracic respiration lags behind the abdominal respiration. So usually the thoracic respiration lag and the abdominal respiration take the upper part. And the last stage of this, particularly the stages of anesthesia, are the stage of medullary paralysis or the cessation of breathing to failure of circulation and death. Ultimately, usually the brain get paralyzed and death will be seen. So what are all the signs? Here the pupil is widely dilated, muscles are totally flabby, and pulse is already or imperceptible, and blood pressure will be very low. So if you administer the injectable anesthetics overdose, then you will get this particular state, and it's very difficult to make the patient to recover to the normal. And many of the above indices of the anesthesia have been robbed by the use of the atropine, or the pupillary and heart rate can also be monitored, and the morphine, respiration and pupillary, and so a few of the muscle relaxants like the many varieties of the muscle relaxants and the anesthetic with muscle relaxation like halothane, etc., will induce all the planes of these stages of this surgical anesthesia. So the depth of anesthesia will be very, very high in case of the initiation of this stage of medullary paralysis. And once the patient comes to this particular state, it is very difficult to get him back to the original state is concerned. Even though we use the antidotes, then it is not useful to the patient. If eyelash reflex is present and the patient is making swallowing movement, stage 2 has not been reached. How to confirm the anesthesia has been reached or not? So the patient is making swallowing movement. If you observe the throat region, then the involuntary swallowing movements you can see on the patient, and it indicates that stage 2 has not been reached at all, the delirium stage. The loss of response to painful stimuli, especially pressure on upper nasal border of the orbit, and stage 3 has been reached. Means if we pinch the pressure on upper nasal border, then if the animal is not responding, means we can say that the stage 3 has been reached. And incision of the skin causes reflex increase in respiration, BP rise, or other effects. Insertion of endotubular tube is resisted and induces coughing, vomiting, and the laryngospasm. Many times the tears appear in eye, passive inflation of the lung is resisted, and anesthesia is very, very light in this stage. So, the fall in the blood pressure is seen. Cardiac and respiratory depressions are the signs of deep anesthesia. So, the heart rate and respiratory rate both are decreased to a maximum extent, so that the patient will breathe in a very slow and feeble manner, and the heart rate also becomes very, very slow in case of the stage 3 surgical anesthesia is concerned. And usually most of the surgeries are conducted in this particular stage. So in the present days, what is there is a practice is anesthesia is generally kept very, very light. Adequate analgesia, amnesia, and muscle relaxations are produced by the use of initial administration of the intravenous drugs, which is maintained by the inhaled agents. And pre-medications with CNS depressants and opioids and their concurrent use lower maximum alveolar concentration of the anesthetic. Means if you administer sometimes the ketamine xylazine combinations or thiopental sodium to the animal and induce or maintain the anesthesia by an inhaled anesthetics, then the lower MAC of the inhaled anesthetic is sufficient to induce the complete anesthesia. So when there is a combination of two inhalational anesthetics, that's the nitrous oxide and isoflurane, the MACs are additive, maximum alveolar concentration are the one. So once again, to make you to remember the MACs or maximum alveolar concentration is the one, the concentration of the anesthetic in alveoli or the airway, which induces the analgesia and anesthesia in 50% of the patients. So the lower concentration of each is required. Example 0.5 MAC of nitrous oxide or the laughing gas is 53% and zero point 0.5 MAC of the what you call as the isoflurane is 0.6%, and these produce CNS depression equivalent to 1 MAC of isoflurane alone, because isoflurane is a potent anesthetic. So the MAC of the isoflurane as well as the nitrous oxide are almost all they are similar in nature. The dose response relationship of the inhalant anesthetic is very, very steep. Just 30% of higher concentration of immobilizers and 95% of the subjects. So the concentration of inhalation anesthetics exceeding 1.5 MAC are rarely used, and 2 to 3 MAC is often lethal. That means it is going to take the patient to stage 4 this anesthesia, or also called as stage of the medullary paralysis. And anesthetized subjects generally wake up when anesthetic concentration falls below zero point 0.4 of the 24.24.4 of the MAC. So the concentration as it is decreases, the patient is going to arouse or he is going to recover from the anesthesia. So this is about the concentrations and certain terminologies of anesthesia, and coming to the mechanism of the general anesthesia is concerned. The Mayer-Overton rule is a unitary theory of the anesthesia. This is a very specific rule. Always this is a FAQ, frequently asked question. What is a Mayer-Overton rule? So here the lipid water partition coefficient is important. Then the gases are highly lipid soluble, therefore they can easily enter the neurons after passing the blood brain barrier. So after entry, the agents they cause disturbance in the patient's consciousness. Then the after entry they cause disturbance in the physical chemistry of the neuronal membrane, and this is known as the fluidization therapy. So they change the varieties of the physical chemistry of the neuronal membranes, and this is known as the fluidization therapy. And finally, obliteration of sodium channels and refusal of the depolarization, it occurs. And the coming to the potency of a gas correlated with its solubility in olive oil, the or olive oil or water coefficient or the ratio, and here the lipid bilayer as only target for the anesthetic action, and clear exceptions have been found now in between so many anesthetic agents. The unitary theory has been discarded totally now, whereas the Mayer-Overton rule is somehow it is ongoing. And the for the inhalation anesthetics, the minimum alveolar concentration or MAC 1 is defined as the minimum alveolar concentration that prevents the movement in response to surgical stimulation in 50% of the subjects and correlates with oil gas partition coefficient usually. And practically, alveolar concentration can be monitored continuously by measuring end tidal anesthetic concentration using the spectrometry. And the end point, especially the immobilization, can be assured, can be measured. And other endpoints are the verbal commands or memory, etc. So if you give some commands orally to the patient, he will hear. That's also the another practicality. For the intravenous agents, potency of IV agent is defined in the different patterns, whereas the MAC is a standard terminology for the gaseous anesthetics, whereas the potency of IV agent is defined as the free plasma concentration at equilibrium that produces loss of response to surgical incision in 50% of the subjects. To repeat again, the free plasma concentration at equilibrium that produces loss of response to surgical incision in 50% of the subject, just like the MAC, maximum alveolar concentration. So it is very difficult to measure. Of course, the no availability method to measure blood and plasma concentration continuously, suddenly, it's just like pricking a probe inside the artery or the vein and monitor it on the using a machine. That's not possible now. Whereas the free concentration at the site of the action cannot be measured. So this is a very difficult situation. The anesthetist, by his own experiences, he has to study all these things and determine what quantity of the anesthetic need to be administered. Whereas the MAC explain only capacity of the anesthetics to enter the central nervous system and attain sufficient concentration, but not the maximum action, mode of action. The mode of action of the anesthetic is not going to be explained by the MAC. And the modern theory on mechanism of general anesthesia. So the general anesthetic mainly act by interaction with membrane proteins. So they may be receptors. The different agents, different molecular mechanism is there, and few of the agents will act using a common mechanism. So major sites of the anesthesia are the thalamus and RAS, the array system, and the hippocampus and spinal cord. These are all the major sites of the anesthetic effect, and the major targets are ligand gated ion channels usually. The important one in among these things is the GABA A receptor, the gated chloride ion channel complexes. GABA A receptor gated chloride ion channels are very important in induction of the anesthesia. And the many inhalant anesthetics are acting by this specific mechanism, especially the maybe the halothane ether, and of course the barbiturates and benzodiazepines and the propofol. It induces the anesthesia by with uh, with the action on the GABA A type of the receptors. So what happens if they come and bind with the GABA A type of the receptor? It is going to potentiate the GABA A to open chloride channels. So also direct activation of the chloride channel, especially the barbiturates, and they are going to increase the bind with the chloride ion channels. Then there will be increase in the inflow of the chlorides, and there will be unconsciousness will be seen. So you can see the structure of the GABA. So it is a different structure than that of the earlier receptors. It is having varieties of the sites, receptor sites on the membrane, and its neurons at the synapse is concerned. So GABA is an endogenous compound, causes GABA A to open. Gamma amino butyric acid is a neurotransmitter. It is going to cause the GABA to open. Whereas the general anesthetics don't bind at the same site with GABA. So usually the GABA is going to bind with that of the alpha side, whereas the alpha, beta, and gamma type of these subtypes of this protein, particularly GABA A receptor complex will be present, and the alcohol is going to act on the base stem of the GABA A receptor, and it's going to bind with that of the particular site. And whatever may be the drug, ultimately the chloride ion channel is going to open inside from outside, and it is going to induce the anesthesia, the benzodiazepines and the ethanol. They are going to act on different site. The barbiturates are going to act on this particular site very near to the alpha, beta and gamma type of the subtype of the receptors. So the GABA A receptor gated chloride ion channels are normally they mediate the effect of gamma amino butyric acid, the major inhibitory neurotransmitter in the brain. So GABA A receptor found throughout the central nervous system. Of course, this type of the receptor is present in the worms, especially in the roundworm, and ivermectin is going to act and cause the excitation of this type of the receptors. So there is the paralysis of the worms, whereas the ivermectin is not going to cross the blood-brain barrier, hence no effect, especially on the other mammals. And most abundant type of the receptors, they are the inhibitory type of the receptor. And if you use the agonist GABA, then the action of the GABA on the GABAergic receptors is going to increase the chloride ion concentrations inside the neuron and going to have the unconscious action. So this is located in the postsynaptic membrane, and ligand binding causes the conformational changes, especially in the leading to opening up of the central pore of the chloride ion channels. So the concentration gradient is there. So it is going to open inside, and net inhibitory effect reducing activity of the neurons. So we know that if the chloride ion this it's activated, there is hyperpolarization in the normal cell. Whereas here also the same thing happens, more and more chlorides if coming inside the cell or the neuron, then there is more and more unconsciousness will be present, and general anesthetics bind with these channels and cause opening and potentiation of these inhibitory channels, leading to inhibition and anesthesia. Here you can see the GABA receptors. They are going to bind with that of the barbiturates or on a specific site. They are going to bind, whereas the steroid type of the anesthetics and the GABA is going to bind with that of alpha and gamma and beta, all the type of the subtypes. Then the ethanol is going to act on the base of this GABA receptor complex. And another neurotransmitter is there, that's the glycine. Glycine activates the chloride ion channels, the spinal cord and medulla. So the barbiturates, the propofol and other inhalation anesthetics are also acting on this particular type of the receptor. Then the another thing, the NMDA, the ketamine and the other anesthetics, dissociative anesthetics are acting through NMDA, N-methyl D-aspartate type of the glutamate receptors, or the aspartate and glutamate type of the receptors are also very, very important. Whereas this nitrous oxide and ketamine, they selectively inhibit the NMDA type of the receptor. They are not going to act on the GABA, but the nitrous oxide and ketamine. So that's why it produces a very characteristic type of the anesthesia, ketamine. So it is known as the dissociative anesthetic, ketamine. Usually it is used in case of cats and dogs for the minor surgeries are conducted. Of course, in case of human being also, the ketamine is used very commonly. And these inhibit the neuronal channels gated by nicotinic cholinergic receptors, and the analgesia and amnesia is induced. The classical example of the agents which are acting through this type of the receptors are the barbiturate and fluorinated anesthetic, isoflurane, sevoflurane, and many type of the fluorinated anesthetics are going to act in similar pattern. And coming to the classification of the drugs in general, mainly the general anesthetics are classified into the inhalant type of the anesthetics and the intravenous type of the analgesic. Inhalation is usually caused by the gases. Usually, it's a gas is a nitric oxide, whereas the inhalation anesthesia is also caused by the volatile liquids like ether, halothane, enflurane, isoflurane, and desflurane and sevoflurane, or the fluorinated anesthetics. Whereas intravenous anesthetics are induced by varieties of the drugs like the thiopentone sodium, methoxetan sodium, propofol, and etomidate sodium. And all these are the administered through the veins. Whereas the benzodiazepines are very slowly acting anesthetics, and the drugs classical example of this category are diazepam, lorazepam, then the lidocaine and midazolam. And dissociative anesthetics, dissociative anesthetics are ketamine and ketamine or ether, the ketamine, ketalar, etc. They are going to act on the NMDA type of the receptor. Whereas the neuroleptic analgesia is the another type of the these anesthetic agents, the fentanyl and droperidol. They are all the neurolept analgesia. So we have to study all these agents in detail in the forthcoming contact hours or the classes. So tomorrow we are going to learn about the in detail about this particular class of the drugs, what are all the inhalation type of the anesthetics, intravenous and different agents, how they are going to induce the anesthesia, and also the different type of the anesthetic agents with the different type of the mechanism of action.